Imagine for a moment your hand has a slight tremor, maybe one you didn't ask for.
Hmm.
Or perhaps getting out of a chair feels, well, really difficult, like wading through treacle.
Yeah,
That little glimpse into your body not quite doing what you want it to, that's really at the heart of what we're diving into today. Parkinsonism.
exactly. We're taking a closer look at Parkinsonism, this condition that gradually affects movement.
Right.
And we know many of you have encountered this, perhaps looked into it. And our goal today is to try to make sense of the detailed information you've shared with us.
Yeah, you've given us some pretty dense medical texts.
They are quite detailed.
And our mission really is to pull out the essential understanding of what's happening in Parkinsonism and, crucially, how medication actually helps manage it.
Right.
We want to give you the key insights without getting too bogged down in, overly technical jargon.
Precisely. We'll be exploring what these medical sources tell us about how Parkinsonism develops and the main ways that medications are used to address it. We want to provide a clear picture, basically, of the underlying causes and the primary role of these drugs.
So let's start with the fundamental question then. What exactly is Parkinsonism? What are the sort of telltale signs?
Okay, well, at its core, Parkinsonism usually presents with four main movement-related symptoms.
Four main ones.
Yeah, there's a stiffness in the muscles, muscle rigidity, then tremors, often noticeable when someone's at rest.
Okay.
Then there's bradykinesia, which is a real slowness in starting and carrying out movements.
Bradykinesia, right. Slow movement.
And finally, postural instability. That leads to problems with balance, later on, usually.
And what's actually going on inside the body to cause these changes? What's the engine trouble here?
Well, the primary issue, the root cause, is the progressive loss of specific brain cells.
Okay.
We're talking about dopaminergic neurons located in an area called the substantia nigra.
Dopaminergic, so they produce dopamine.
Exactly. Dopamine is a vital chemical messenger, a neurotransmitter in the brain. When these cells die off, it creates an imbalance.
An imbalance between what?
Between dopamine, which generally helps to, let's say, smooth out movements. It's inhibitory in this context.
Yeah.
And another neurotransmitter called acetylcholine, which tends to excite muscle activity.
Oh, okay.
And this imbalance occurs in the brain's main movement control center, the extrapyramidal system.
Dopamine, we often hear about it with, like, pleasure and reward systems.
That's true.
But it sounds like its job description is much broader than just, making us feel good when we eat chocolate.
Absolutely.
Yeah.
While it's definitely involved in those reward pathways, dopamine has many, many other crucial roles.
Such as?
Well, our sources really emphasize its importance in controlling voluntary movement, obviously, but also influencing our mood, our thinking processes, cognition, memory, learning, even sleep cycles, appetite, and the regulation of a hormone called prolactin.
Wow, okay. So a drop in dopamine levels can have really widespread effects then.
It certainly can.
Now, these medical texts you mentioned, they talk about something called the basal ganglia. What are they and what's their usual role in keeping our movements, fluid and normal?
Right, the basal ganglia. Think of them as like the brain's movement coordination hub.
Uh-huh.
Yeah, a group of interconnected structures deep inside the brain. In a healthy brain, they receive signals from the cerebral cortex, that's the brain's outer layer, responsible for higher-level stuff like planning movements.
Okay.
The basal ganglia then process these signals and send refined instructions back via the thalamus to the motor cortex, which directly controls our muscles.
Ah, so it's a loop.
Exactly. This loop is essential for making our movements smooth and coordinated, like a well-oiled machine.
Okay, so what happens in Parkinsonism to sort of throw a wrench in this finely tuned system? How does this whole communication network get disrupted?
Well, in Parkinsonism, the loss of those dopamine-producing neurons in that pathway, it's called the nigrostriatal pathway, linking the substantia nigra to the striatum. That loss leads to increased braking, you could say, on another brain region called the thalamus.
Increased braking.
Yeah, inhibition. The thalamus acts like a relay station, passing signals onto the motor cortex. So with this increased braking, the motor cortex receives fewer go signals.
I see.
And this reduction in input ultimately results in the stiffness and slowness of movement, that rigidity and bradykinesia that are so characteristic of Parkinsonism.
It's like the movement instructions are getting stuck in traffic.
That's a good analogy, yeah. Less dopamine basically means the move command isn't getting through as effectively or as strongly.
Okay.
And there's another factor, too. The reduced dopamine also leads to an overactivity of acetylcholine in that striatum area.
Ah, the other chemical.
Remember, acetylcholine tends to excite muscle activity. So with less dopamine there to balance its effects, this relative surge in acetylcholine also contributes to the problems.
So it's like the accelerator's being pressed too hard while the brake is sort of failing.
That's a very good way to think about it, yes.
It's really amazing how this delicate balancing act of brain chemicals is so vital for something we usually take completely for granted just moving around.
Absolutely.
One of the sources even includes a visual description. I remember reading, posture in Parkinson's disease. Note the slight stoop and the position of the right arm.
Hmm.
That really paints a picture of the physical changes, doesn't it?
It does. That image highlights those typical changes in posture and maybe subtle differences in how someone holds their arm, things like that.
Right.
Now, when it comes to actually managing Parkinsonism, medication plays a absolutely central role.
Okay.
And these medications generally fall into two main categories.
Two main types.
Yes. Those that work on the dopamine system, we call them dopaminergic drugs. And those that affect the acetylcholine system, which are anticholinergic drugs.
Dopaminergic. Okay, that makes sense. Trying to boost the dopamine that's missing. What are the different ways these drugs work?
Right. So within that dopaminergic category, we have several different approaches. First, there are dopamine precursors. The most important one here is levodopa, often just called L-Dopa.
L-Dopa, heard of that one.
Then we have something called COMT inhibitors, like tolcapone and entacapone.
COMT inhibitors.
And selective MAOB inhibitors.
Mm-hmm.
Selegiline is the main one there.
MAOB.
Then there are dopamine agonists, drugs that mimic dopamine, like bromocriptine, pramipexole, apinarole, and epimorphine.
Wow, quite a few agonists.
And finally, there's a dopamine releaser called amantadine. So it's quite a toolkit available.
It certainly sounds like it. And the other main type you mentioned was anticholinergic drugs. What are the key players there?
The primary anticholinergic medications used in Parkinsonism are benztropine and trihexyphenidyl.
Benztropine and trihexyphenidyl. Got it. Okay, let's zero in on levodopa, L-Dopa. You said it's the most important precursor. It's often talked about as the kind of gold standard, right?
It really is.
Why is it sort of go-to treatment?
Well, levodopa is really the cornerstone of Parkinson's treatment because unlike dopamine itself, it can actually cross the blood-brain barrier.
Yeah, that protective shield around the brain.
Exactly. Dopamine can't get through it, but levodopa can. Once it's inside the brain, it gets converted into dopamine by an enzyme.
So it directly increases dopamine levels right where they're needed in the striatum.
Precisely. It helps alleviate those motor symptoms. So the key insight really is that we're essentially giving the brain the raw material it needs to make more dopamine.
It's like tricking the system a bit. But I remember reading somewhere that getting levodopa to the brain isn't always that straightforward. There's a catch.
That's a very crucial point, yes. Unfortunately, when levodopa is given on its own, a huge amount of it, actually over 95%, gets broken down into dopamine in the body outside the brain.
Oh, wow. 95%?
Yes, in the peripheral tissues. This peripheral conversion not only means much less levodopa reaches its target in the brain,
Right.
but it also contributes significantly to many of the initial side effects, like nausea.
It's like trying to deliver a package, but most of it gets unwrapped before it even arrives at the destination.
Exactly. That's a great analogy.
So how do doctors get around that? How do they make sure more of it actually gets to the brain?
This is where another drug called carbidopa comes in. It's usually given in combination with levodopa.
Carbidopa. Okay.
Carbidopa is quite clever. It inhibits the enzyme that breaks down levodopa, but only in those peripheral tissues outside the brain.
Ah.
Crucially, carbidopa itself can't cross the blood-brain barrier.
So it blocks the breakdown before the levodopa gets to the brain.
Exactly. By blocking this premature breakdown, carbidopa allows a much larger percentage of the administered levodopa dose to reach the brain,
That makes sense.
which means a lower dose of levodopa can be effective. And that, in turn, helps to reduce those troublesome side effects that happen outside the brain.
So the levodopa-carbidopa combination is all about maximizing delivery to the brain and minimizing peripheral side effects. Makes perfect sense. Once it's in the brain and converted, how does it work? It's magic, so to speak.
Well, once it's converted to dopamine, it essentially helps to replenish those depleted dopamine levels in the striatum.
Right.
This improved dopamine signaling then helps restore some balance in the brain's movement control circuitry, which leads to an improvement in motor function. Less rigidity, less slowness.
And what about how the body, handles levodopa? I saw something about maybe needing to take it on an empty stomach. Why is that?
Yes, the body's processing the pharmacokinetics is important. It's absorbed pretty quickly from the small intestine.
Okay.
However, it has a fairly short half-life. It doesn't stay active in the system for very long, typically only about 1 to 2 hours.
Oh, that's short.
It is. And this short duration can contribute to what's called the on-off phenomena.
On-off.
Yeah, those sudden, unpredictable swings some people experience between having good movement control being on and periods where their symptoms return quite strongly, stiffness, tremor being off.
Ah, okay, I see. And the empty stomach thing.
Right. Levodopa competes with certain amino acids, the building blocks of proteins from food, for absorption in the gut.
Ah, competition.
Yes. So taking it on an empty stomach, usually about 30 minutes before food or maybe an hour or two after, helps to minimize this competition and maximize how much levodopa actually gets absorbed into the bloodstream.
Good tip. And what about side effects? What are some of the common things people might experience with levodopa treatment?
Well, the side effects can vary quite a bit. Initially, things like nausea and vomiting can be quite common, especially before the carbidopa really kicks in properly or if the dose is increased too quickly.
Okay.
In the central nervous system, some individuals might experience mood changes, sometimes hallucinations, or very vivid dreams, even nightmares.
Right.
And as we mentioned, that on-off phenomenon can be a challenge. Also, with longer-term use, something called dyskinesia can develop.
Dyskinesia, what's that?
Those are involuntary movements, often sort of writhing or fidgety movements, maybe of the head, face, arms, or legs. And there can also be autonomic side effects. Things like postural hypotension, that's a sudden drop in blood pressure when you stand up, which can cause dizziness.
Right.
Sometimes irregular heartbeats or arrhythmias, and occasionally mydriasis, which is just widening of the pupils.
Okay, that gives us a really good handle on levodopa. Now, let's look at some of those other dopaminergic drugs you mentioned.
Sure.
First up were the COMT inhibitors like tolcapone and entacapone.
Oh, yeah.
Where do they fit into the treatment picture?
Right, COMT inhibitors. They work by blocking an enzyme called catechol-methyltransferase, or COMT for short.
Okay, COMT.
This enzyme, COMT, is another one that breaks down levodopa, mainly in the gut and liver, before it reaches the brain.
Ah, another breakdown pathway.
Exactly. So by inhibiting COMT, these drugs, tolcapone and entacapone, help prevent that premature breakdown. They allow more levodopa to get to the brain.
So they work alongside levodopa.
Yes, they're used with levodopa. Think of them as maybe escorts that help levodopa get safely to its destination. They can help smooth out the effects of levodopa, perhaps extend those on periods, and reduce the off periods for people who are experiencing those fluctuations we talked about.
Right, the on-off thing. And are there any specific side effects linked to these COMT inhibitors we should know about?
Well, tolcapone carries a risk of liver problems, potentially serious ones like hepatic necrosis, so regular liver function monitoring is absolutely essential with that one.
Okay, that's important.
Entacapone doesn't seem to have the same liver risk, so it's generally preferred now. Otherwise, because they basically boost levodopa's effectiveness, they can sometimes amplify levodopa's own side effects, nausea, dyskinesia, things like that.
Got it. Moving on, we had the MAOB inhibitors like selegiline mentioned in the sources. What's their role?
Okay, selegiline. It's a selective inhibitor of monoamine oxidase type B, or MAOB.
MAOB.
MAOB is an enzyme that's actually inside the brain, and its job is to break down dopamine after it's been released.
Ah, so this one works in the brain.
Yes. By blocking MAOB, selegiline helps to slow down the breakdown of dopamine within the brain itself.
So it keeps more dopamine around for longer?
Exactly. It's like putting a temporary cork in the drain, if you like, to keep the dopamine levels up. It can be used alone early on or later with levodopa.
And what kind of side effects might someone encounter with selegiline?
Common ones can include some gastrointestinal upset, like nausea, potentially hallucinations, maybe changes in mood, and sometimes difficulty sleeping, insomnia.
Okay. Now let's tackle the dopamine agonists. This seemed like a bigger group.
It is, yes.
We had the older ergot-derived one, bromocriptine, and the newer non-ergot options like pramipexole and ropinirole,
Yeah.
and also epimorphine. How do these work, and what are the key differences for someone listening?
Right. So dopamine agonists, as the name suggests, work by directly mimicking the action of dopamine in the brain.
They pretend to be dopamine.
Essentially, yes. They bind to dopamine receptors and activate them just as if they were dopamine.
Yeah.
Bromocriptine is an older one, derived from ergot alkaloids. A key difference from levodopa is that it can work even if there aren't many dopamine-producing neurons left functioning.
Ah, so it bypasses the need for conversion.
Exactly. It also tends to have a longer duration of action than standard levodopa and might be less likely to cause that on-off effect initially.
But are there downsides?
Yes, it can have its own set of side effects. Gastrointestinal upset, hallucinations, mood changes, particularly at higher doses, postural hypotension, that dizziness on standing.
Similar to levodopa in some ways.
Yes, but uniquely, because it's ergot-derived, there's a potential, though rare, risk of things like pulmonary fibrosis, lung scarring, and vasospasm.
Okay, that's significant. What about the non-ergot ones, pramipixole and eropanerol? You hear about those more often now, perhaps?
Yes, pramipixole and ropenolol are newer dopamine agonists that aren't derived from ergot, so they don't carry those specific ergot-related risks.
It's good.
They specifically target the D2 type of dopamine receptor, which is important for movement control. These are often used in the earlier stages of Parkinson's.
Why early on?
Well, they can help manage symptoms and potentially delay the need to start levodopa, especially in younger individuals where you might want to save levodopa for later.
Right.
And in later stages, they can be used alongside levodopa to help reduce those off periods and sometimes allow for a lower dose of levodopa.
Okay. And apomorphine, that sounds like it has a very specific use case.
It does. Apomorphine is chemically related to morphine, which is confusing, but it absolutely does not act on opioid receptors. It's a potent dopamine agonist.
Okay.
It's approved specifically for treating those sudden episodes of being unable to move, sometimes called freezing episodes or acute hypomobility that some people with advanced Parkinson's experience.
How is it used then?
It's given by injection, often via a pen injector, to provide rapid relief during one of these off episodes. It kicks in quickly.
Right, like a rescue medication.
Right.
Lastly, in this dopaminergic group, we had amantadine. You mentioned it started out as an antiviral drug. That seems odd. How does it help with Parkinson's?
It does seem a bit odd, doesn't it? That's right. Amantadine was initially developed to fight the flu virus.
Ah.
It was later discovered, somewhat by chance, to have beneficial effects in Parkinson's. Its mechanism isn't perfectly understood, but it's thought to work in a few ways.
Like what?
Well, it seems to stimulate the release of stored dopamine from the remaining nerve terminals.
Okay.
It might also reduce the reuptake of dopamine that's already been released, keeping it active for longer. And interestingly, it also has a weak blocking effect on NMDA receptors.
NMDA?
Yeah, these are receptors for another neurotransmitter called glutamate, which can become overactive in Parkinson's. So blocking them slightly might also help reduce symptoms, particularly dyskinesia.
So it's got a few different angles of attack.
It seems so. It's considered modestly effective, often used for mild symptoms, or sometimes specifically to help with levodopa-induced dyskinesia.
And what are the potential drawbacks or side effects of using amantadine?
Side effects can include some gastrointestinal upset, again, potentially hallucinations or mood changes, that postural hypotension, and sometimes a distinctive skin discoloration called livedo reticularis. Looks like a sort of purplish, blotchy, net-like pattern on the skin, usually on the legs.
Livedo reticularis.
Okay.
It's usually harmless, but can be cosmetically bothersome.
Right. Okay, wow. We've covered a lot of ground with the dopamine-focused drugs.
We have indeed.
Now, let's switch gears, as you said, to the other main category. The anticholinergic drugs like benztropine and trihexyphenidyl, how do they fit into the picture?
Right, the anticholinergics. As we discussed earlier, Parkinsonism involves that imbalance between dopamine, which is low, and acetylcholine, which becomes relatively overactive.
Okay.
While the dopaminergic drugs aim to boost dopamine, these anticholinergic drugs work on the other side of that equation.
They tackle the acetylcholine. Exactly. They selectively block certain acetylcholine receptors in the brain, specifically the muscarinic M1 type receptors. This helps to reduce that relative overactivity of acetylcholine, aiming to restore a better balance with the remaining dopamine.
So it's like gently easing off the accelerator when the dopamine isn't working as well.
That's a good way to put it, yes.
Yeah.
They're trying to rebalance the system from the other side.
So they're not directly addressing the core problem of dopamine loss itself.
No, they're not.
But rather trying to counteract the downstream effects of the relative excess of acetylcholine.
Precisely. And because of that, their main effect is often seen more on reducing tremors. They tend to have a less significant impact on the rigidity and the bradykinesia compared to levodopa.
Ah, interesting. Primarily for tremor.
Often, yes.
Yeah.
Though they can help with rigidity too, just usually less dramatically than levodopa.
So when are these anticholinergic drugs typically used in managing Parkinsonism?
Well, they can be used to help manage Parkinson's symptoms, particularly tremor, although, as I said, they're generally considered less effective overall than levodopa.
Okay.
They also have a specific role in treating drug-induced movement side effects, called extrapyramidal symptoms
Mhm.
that can sometimes occur with other types of medications, like
Mm.
certain antipsychotics.
Right, drug-induced Parkinsonism.
Exactly.
And what are some of the important side effects we need to be aware of with anticholinergic drugs, especially perhaps for someone who might already be dealing with Parkinson's?
This is a really, really important consideration. Parkinson's itself, particularly as it progresses, can sometimes be associated with cognitive impairment or even dementia.
Hmm.
Anticholinergic drugs have a well-known potential to cause or worsen confusion, memory problems, and cognitive difficulties.
Oh, that's not good.
No. So they need to be used very cautiously, especially in older individuals or anyone with existing cognitive issues. They can also cause other typical anticholinergic side effects.
Such as?
Things like dry mouth, blurred vision, constipation, difficulty urinating, urine retention. And they can increase pressure inside the eye, which is a serious concern for people with narrow-angle glaucoma.
Okay, so definitely not without significant potential downsides, particularly regarding thinking and memory.
Absolutely. They have their place, but require careful patient selection and monitoring.
That really highlights the delicate balance doctors have to strike when choosing treatments, doesn't it?
It really does.
Now, just briefly, our sources also included a few quiz questions related to treatment choices. How do those kinds of questions tie into the practical principles we've just been discussing?
Yeah, those quiz questions, they really underscore some key practical aspects of treatment, I think.
Mhm.
For instance, the emphasis you might see on sustained release formulations of carbidopa-levodopa as a common first-line approach. That highlights the importance doctors place on trying to provide a more stable, consistent level of medication to avoid those peaks and troughs.
Right, tackling the on-off issue.
Exactly. And the fact that other drugs, like the dopamine agonists or the COMT inhibitors, are mentioned as ways to optimize treatment, maybe add-on therapies, that reinforces the idea that often managing Parkinson's effectively requires a combination of medications.
So it really brings home the point that Parkinson's treatment isn't a one-size-fits-all scenario.
Not at all.
Yeah.
It needs to be highly tailored to the individual patient, their age, their specific symptoms, the stage of their condition, other health issues, how they tolerate medications.
It's about finding the right recipe, the right combination for each person.
Precisely. And it's often an ongoing process, too. Adjusting medications and dosages over time to keep symptoms controlled as well as possible while minimizing any troublesome side effects. Everyone responds a little differently.
Well, we have certainly covered a huge amount of information today. It's been really insightful.
Hmm.
So just to recap the main points for everyone listening, Parkinsonism is fundamentally a movement disorder driven by that loss of dopamine-producing brain cells, leading to a range of motor symptoms like tremor, stiffness, slowness, and balance issues.
Yes.
The main treatment strategies really revolve around boosting dopamine levels in the brain, primarily using medications like levodopa, often with carbidopa,
The cornerstone, yes.
or by mimicking dopamine's effects with the dopamine agonists.
Mhm.
And then we also have drugs that help preserve the dopamine that's already there, like the COMT and MAOB inhibitors.
Right.
And finally, medications that target that other neurotransmitter system, the anticholinergics, aiming to help restore that crucial balance.
That's an excellent summary. We've really delved into the complexities of Parkinson's pharmacology today, how these different classes of drugs work, their mechanisms, and also some of the potential challenges and side effects that come along with them.
It's clear from all the material that this is a highly intricate area of medicine. We really hope this deep dive has given you, our listener, a much clearer understanding of the pharmacological approaches used to manage Parkinsonism based on the detailed information you shared with us.
Absolutely. And maybe just a final thought to leave you with.
Okay.
Considering those far-reaching roles of dopamine that we touched on earlier, beyond just movement, influencing mood, cognition, sleep, reward, so much more, it really prompts an important question, doesn't it?
Which is?
How might future therapies for Parkinson's aim to address these broader, non-motor aspects of the condition in a more integrated, more holistic way? It's definitely a fascinating and vital area to watch as research continues to push forward.
That's a great point. Moving beyond just the movement symptoms. Food for thought indeed.